Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can find our previous episodes on Apple Podcast, Spotify, Google Podcast, and on your favorite podcast app. I have to say that gout is not the sexiest topic within rheumatology. I mean, humans have known about gout for about 5,000 years, starting with the Egyptians who first described podagra. Even Hippocrates recognized gout as the unwalkable disease. Colchicine was first used to treat gout 1,500 years ago, and allopurinol was approved to treat gout more than 50 years ago. And while we can actually cure the disease in specific patients, we're really lousy at treating populations of patients with gout. Studies show that only a minority of patients with gout that qualify for urate-lowering treatment actually receive any. And of these, an even smaller percentage actually reach target uric acid goal. To better understand these discrepancies and identify better ways of managing gout, we've invited Dr. Nicola Dalbeth. She's a specialist rheumatologist and professor of medicine from Auckland in New Zealand. She leads a research program that focuses on the mechanisms, impact, and treatment of gout. She has been the principal investigator of trials for novel therapeutic agents and treatment strategies in gout, and has led international initiatives to define central concepts of the disease, including nomenclature, staging, and response to treatment. She was a member of the core oversight team for the 2020 American College of Rheumatology Gout Management Guidelines, which should be required reading for any rheumatologist, and we'll actually have links to this document from our website. And she was also a steering committee member of the 2015 ACR EULAR Gout Classification Project. I have to say that after speaking with Nicola, I've developed a newfound excitement for managing patients with gout, and especially in helping to address some of the disparities and gap in its management. Enjoy. Nicola, welcome to the show.
Thanks. Nice to be here, John.
Good to see you from the other side of the world. So we brought you here to talk about gout. And, it's taken us 50 episodes to finally talk about gout. It seems like in my reading, gout is the most common inflammatory arthritis in the world, but perhaps it doesn't get the respect that it deserves. Why do you think that is?
Yeah, it's really interesting, isn't it? It's absolutely core rheumatology. It's something that all of us in our rheumatology practice are seeing regularly, and yet it's not something that often has the same priority. We see this in the number of publications, the number of studies that are done, our own attitudes, I think sometimes, it's just gout. I think it's a really interesting thing. I'm not sure if that's because we've had effective treatments for so long, really since the 1950s. So there hasn't been that kind of explosion in treatments that we've seen in other aspects of rheumatology over the last 20 years or so. But it's a really common, view of the disease. It's absolutely core rheumatology, most common form of inflammatory arthritis. It's something we should all be doing really well, and we're not really doing very well.
Yeah. Tell me a little bit about that. I mean, you just mentioned that we've had effective treatments for gout for decades, and yet it doesn't seem like we do a very good job of actually treating patients with gout.
Yeah, and I think this is kind of the tragedy of it, really. We know that allopurinol has been available for half a century. Colchicine, probenecid, these are medicines that have been used for decades, as you say. Yet we know that, most people with gout don't get their serum urates to target. We're seeing increasing hospitalizations due to gout, increasing disability and burden of disease. And so much of this is actually preventable with these low-cost medications that all of us should be able to use well.
Crazy. So what do you think are the barriers, both from a physician perspective and a patient perspective, to appropriately treat gout?
I think there's a number of things there. So I think one of the real challenges is the disease course itself, where you can have these prolonged periods of feeling really, as a patient with gout, of feeling really well. And then this intensely active inflammatory disease, which, is extremely painful, very disabling, which settles down over a couple of weeks. And then the person can feel completely well again. So I think from a patient perspective, often there's a sense that this is an acute flaring disease, that this isn't actually a chronic disease. And I think as physicians, we see the disease in the same way. We see people being well, and then we see very intense inflammation, and we know how to treat that inflammation. And so I think there is something about the condition itself, particularly this intermittent flaring disease, where there's long intercritical periods where the person feels well. And I think that that is a real challenge cognitively for both patients and also for physicians, particularly if we don't understand the underlying basis of the disease as a chronic disease of MSU crystal deposition. So, I think that's a really important concept for both healthcare professionals and also for patients. I think there's a lot of narratives around gout, which are again sort of very embedded within our culture, which again are, as healthcare professionals, we are also affected by these narratives around the cause and solution for gout being all about dietary management. I certainly would not say diet and dietary advice and diet management isn't part of gout management, but often for patients, it's all they hear. And so, there's this kind of concept that you have to earn your allopurinol, that, you only get allopurinol when actually you've had lots of flares. And actually, if a person's having 2 flares a year, there's a strong recommendation that actually they should be receiving urate-lowering therapy. Yet so often people aren't receiving that. And then when they do receive it, the kind of doses of allopurinol that are given, or indeed febuxostat, are often inadequate as well. So often people are not offered urate-lowering therapy. They're given advice about treatments which are not particularly effective. And when we're using urate-lowering therapy, we're not treating to target effectively. So there's a whole lot of challenges in there, really. And there's a lot of work that we need to be doing as rheumatologists to really help the community, other healthcare professionals, build that understanding about gout and its effective treatment.
Yeah. And it's so interesting. So I asked my wife what she knows about gout, and she's a pediatrician, so I didn't expect her to know much. And what she said was it's older men, and it has something to do with purines in the diet, and you treat it with colchicine. And I feel like that's often what we hear even from internists, right? The idea that it's just men, that it has to do with diet, and that the management is sort of you treat these episodes with colchicine.
Yeah.
Where did that come from? I mean, it's probably from medical school, right? That's what we learn about gout. Can you unpack that a little bit? So is gout a disease of men?
So my concept about gout I think it's really changed a lot, really, in the last 10 to 15 years as we understand more the biological basis of gout. And much of this has come from genetic studies, of these big GWAS studies. And I think it's become very clear that actually gout is primarily a disease of urate excretion, actually. So through the gut and also the kidneys. So I think really the sort of major learning that we've had from these very large population-based studies is that the pathways that are most associated with both hyperuricemia and also gout are not purine metabolism pathways. They're actually renal urate transporters and gut urate transporters. And actually, the really major reason for developing gout for most people is, in fact, the way that the kidneys and the gut handle urate. And so our environment has an impact on that. I don't think any of us can argue about that. We know that, higher BMI, for example, will also influence urate transport within the kidney. But actually, this concept that gout is all about purines and about the purines that we eat is actually really, it's quite outdated, but it's something that all of us learned at medical school. Well, I certainly did, And so, again, we have these kind of medical narratives that are very much aligned with our cultural narratives as well around the causes of gout. And we need to be updating ourselves and updating our patients about this. I think the issue of treating gout with colchicine is a really...
Or indomethacin, right? That's the other one that we often see.
Well, yeah, that's right. And, I think it's really important to kind of think about what we're trying to achieve with our various treatment strategies. So, I think there's really sort of three major aspects of gout management. The first thing, which is really important, is to effectively treat and manage the gout flare, which is, incredibly distressing for patients. And we, as rheumatologists, again, we need to be thinking about that and really doing that well. We can't just say, oh, you'll feel so much better in a year once you've been on allopurinol for all that time. Actually, that's not useful for the person who's got a gout flare in front of you. So actually making sure that the person has an action plan for managing flares, treating flares as soon as they start to get that tingle in their joint, doing that safely. And that is with corticosteroids, oral prednisone and or colchicine and or NSAIDs. And, that's part of the whole treatment approach. We then have these kind of longer term approaches, which are both urate lowering, but also thinking about preventing flares while that urate lowering therapy is really becoming established. And again, I think often we don't do that very well. So I think one of the real challenges for patients is we say to them, oh, we're going to give you this allopurinol. It's going to be great. It's going to sort your gout out. It's brilliant. And then, we give them allopurinol, often at too high a dose to start with, and then they get a terrible gout flare. They lose faith in the doctor who's told them this, and they never want to take allopurinol again. So that's, I think, really where that role of colchicine comes in. And I think particularly in that early phase of the disease where we're starting urate-lowering therapy, we need to be thinking both about the urate-lowering therapy and also about the anti-inflammatory gout flare prevention as well, and doing both of those things well, because if we don't do both of them well, the person's never going to actually be well established on urate-lowering therapy.
Yeah, I think that's such an important point that often gets overlooked. When I get patients referred to me who have had gout, for decades, we ask them about allopurinol and they're like, yeah, I tried it once and it caused a flare and I never tried it again. So should there be like a warning every time you prescribe allopurinol, saying something like, hey, if you're going to increase the dose or prescribe this for the first time, this should really be used with a medicine like colchicine?
Yeah, so I think there are a couple of strategies there to prevent gout flares in that early stage of initiating allopurinol or any urate-lowering therapy. And I think there's really two things. One is the role of anti-inflammatory prophylaxis. So this is basically low-dose meds that we use to treat, the same meds that we commonly use to treat flares. So that's essentially low-dose colchicine, which has by far the best evidence base. Sometimes we'll also use instead NSAIDs such as low-dose naproxen. I'll sometimes use low-dose COX-2 inhibitor, or occasionally actually low-dose prednisone. There's not really good data on that, but in reality that's something that sometimes we have to use for someone who's flaring a lot. The other thing that's also really important when we're starting urate-lowering therapy is to start low and gradually dose titrate. And again, there's some really good data now showing that when we do that, actually we don't see excessive flares in that setting. So that does take a bit more work. So, it's much easier to say to a person, oh, here, take 300 milligrams of allopurinol and continue with that. It's more complex to say, okay, well, you're going to have to start with 50 milligrams or 100 milligrams, and then every couple of weeks or every month just increase it. So there's a degree of complexity around there. And I think often when a person's got a gout flare, there's a whole lot of other stuff going on. They can't get to the bathroom. They're missing time off work. There's financial problems. Actually, it's really hard to have those conversations and for the person to kind of take in all that complex information. So, and maybe we can talk a bit more about some strategies to help build that understanding and think about other members of the healthcare team who can also support that patients through that. One of the other things that I often do in that situation as well is actually use blister packs, because that also actually just takes some of the complexity out of that situation as well, where actually the medications for the first month or even 3 months are packed up for the patient by the pharmacist. So actually there's less complexity around that for the person to follow instructions each day. And I think that also helps quite a lot.
Got it. So you would pack the allopurinol with the colchicine.
Yeah, and particularly when you're looking at that dose escalation as well. So, when you're actually looking to potentially continue with that colchicine plus increasing the allopurinol dose every 2 to 4 weeks, I think that also makes that much more straightforward for the patient until they're on a stable dose of allopurinol.
Yeah, you're right. And thinking about it, it does take a lot of work. When you tell patients is like, in a couple of weeks or in 4 weeks, go get your blood work. I'll let you know whether to increase it and whether you're tolerating the medication well. It's certainly probably expensive. It's bothersome for the patient to be able, to go get to the lab and get it drawn. It may be expensive for them. And then we have to review that data and sort of make a decision about further treatment, increase their dose. So are there other strategies that you think can be helpful in managing sort of the treatment of gout?
Yeah, so look, I think it's sort of really interesting when you sort of start talking about the work that goes on about this. And it's sort of really interesting, actually, I think so often as rheumatologists, we think of gout as being sort of easy compared to other maybe rare autoimmune diseases or even more sort of common autoimmune diseases where we're using lots of biologics or, other immunosuppressive therapy. But actually doing gout well does take time. And when I say doing gout well, I mean actually helping the patient get control of this chronic condition. And I think there's some really good data now showing that other members of the healthcare team, nurses, pharmacists, are very skilled at this and actually can make a big difference as well. So I think if we think about all the trials that have been published in gout, to my mind, the most important practice-changing trial was the Nottingham nurse-led gout trial published in The Lancet in 2018, led by Mike Doherty. And this was a really important trial of nurse-led care embedded within primary care, demonstrating that nurse-led care, which was very much a health literacy approach, looking at what patients understood about gout, building on that understanding, a treat-to-target approach, just led to incredible outcomes and major improvements, far better than, the standard usual care. To my mind, I think that's really where we need to be pushing gout care. There's a lot of people with gout in our community. As rheumatologists, we're not going to be able to treat every one of those patients and give them that really excellent care that they need. And I think it's very clear that trained healthcare professionals who are not doctors, particularly nurses and pharmacists, have a really big role to play here. They have a lot of skills in this area and the outcomes are much better. So I think there is a clear role for rheumatologists to facilitate this, to provide the support and the medical oversight when that's needed. And also, I think, there will be situations where actually the standard approaches with allopurinol, the kind of standard treat to target may not work because of medication intolerance or a lot of other medical complexity. And I think that's certainly where we should be seeing patients in our services. But actually, for the vast majority of patients, what they really need is they need someone who understands gout, can provide that initial information, ensure that the medications are appropriately titrated, and then also And I think really importantly, ensure that there's an ongoing supply. Because the other thing that we often see is people come to see us, their serum urate's beautifully controlled, they're on the right therapy, and then something happens and they fall off the allopurinol, and then a couple of years later they're presenting with tophi, gout flares, and all of the impacts of really severe gout, the impact on their work, their family life, the severe pain, the NSAIDs and the terrible consequences of long-term NSAID use. And a lot of that is preventable, but we need to be thinking not just about what we're doing at the start, but actually making sure that this long-term condition is managed well in the long term.
That's really interesting. It reminds me of the warfarin clinics that many hospitals have, right? Like patients that are on warfarin, they're hooked up with the nurse and, they get the blood work and they get titrated their medications like all the time. It sounds like maybe that's what, we should set up.
Yeah, absolutely.
And from what you're saying, that should be embedded within the primary care clinic, not necessarily in the rheumatology clinic.
Yeah, and I think, ultimately, I think gout should be primarily managed well in primary care. And again, primary care physicians are good at managing long-term conditions and should be able to manage this well. And I think often they do, actually. And I think as rheumatologists, we need to support them in doing that. Again, thinking about not only primary care physicians, but actually other members of the primary care team as well. Now, that will depend in part on healthcare systems and what works, say, maybe in the NHS in the UK may not work in Aotearoa, New Zealand, may not work in the US. But, I think that we need to be looking within our healthcare systems. And there's some great examples of this, actually, of people establishing these kind of clinics in the US as well, actually, these multidisciplinary clinics, and a lot of treatment success there as well. So I think we really need to be looking at these models more and more.
Yeah. So maybe that's perhaps why gout doesn't get the respect it deserves. Like on the one hand, it's like fairly simple, right? We have like all these medicines and we know how to treat it. But on the other hand, it's like, it's sort of really complex to actually implement those strategies. And maybe that aspect of implementation is just like hard to grapple, as opposed to like a fancy new drug that you could just give patients and take care of their disease.
I think the other real challenge with urate-lowering therapy is that it does take quite a long time to see the benefits. And so again, I think, if you're treating someone, I think of those early days of biologics where, we had people who were incredibly disabled by their rheumatoid arthritis, who we gave infliximab to, and suddenly, they were walking around. It was amazing. And, I think we see that kind of pretty immediate, within a few months, transformation with, say, biologics, for example, in inflammatory rheumatic diseases. And yet, with gout, often the urate-lowering therapy is not, it takes many months, sometimes many years to see the full benefit. And I think that can be really challenging for both patients and also, healthcare providers as well. And again, I think it's that kind of very clear communication about gout and actually, this is not going to be solved overnight. And over time, you will find that your gout flares become less frequent, less severe until gradually they settle down completely. But these lumps, these tophi, they will soften and they will gradually reduce over time, and eventually they will disappear. But this isn't with oral therapy going to happen overnight. It will take a number of months. And so I think it is that kind of managing expectation and sort of seeing it in the long term rather than just the what's going to happen in the next 2 weeks. And that, again, is very challenging when you've got an intermittently flaring condition. Makes a lot of sense to take a medicine when you're in severe pain, not so much when actually the pain has disappeared.
Great. So let's take a step back a little bit and talk about the diagnosis of gout. Certainly gout, fairly easy, at least for rheumatologists to diagnose when it presents with podagra, right? You see you can't miss the big red toe, right? And the story of the person waking up and all of a sudden having toe pain without having stubbed their toe. But there's some scenarios that are tricky in that it's maybe it's ankle pain, or maybe it's knee pain. Maybe it's something that looks like seronegative RA. So what's the role for imaging for diagnosing gout in some of those settings?
Yeah, it's a really interesting question. And I've kind of thought about this quite a lot. We did a lot of the really early dual energy CT studies. And, dual energy CT is kind of amazing because you see these, you can see the disease, see it in a really new way. It was, I think, really exciting when we first started seeing these beautiful 3D reconstructions, and actually were really able to visualize the crystals in a way that we really hadn't before. And I think that's also the case with ultrasound, actually, in the clinic, for example. My own experience is that actually I think most of the time you can still make the diagnosis of gout using your standard clinical method. So, history, examination. Usually there is a history of acute inflammatory episodes, which are pretty typical for gout. Usually, if you've got someone who's got a chronic arthritis, polyarthritis due to gout, there will be a long history of gout flares, or there'll be tophi, or there'll be something else that really looks like gout. So I think even in rheumatology practice, it's usually possible to actually make the diagnosis with history and examination. There are obviously some situations where it's more complex, where there's maybe two diagnoses, or there is an unusual nodule, or, there is a sort of unusual inflammatory polyarthritis, which kind of could be gout, but maybe not. And I think there's a number of different ways to go about diagnosis in this setting. I think ultimately MSU crystal diagnosis by microscopy is still the gold standard. And I think if in doubt, tap the joint and go for the microscopy. I think certainly dual energy CT and ultrasound can be very valuable in this situation. And I think particularly if you're not sure whether gout is causing everything, all of the symptoms, I think in that situation, I certainly find ultrasound really valuable there. I think with dual energy CT, usually if you've got enough deposition that you're seeing it on dual energy CT, you'll be seeing it clinically as well in reality. So I think there's the odd situation where you have a nodule and you think, oh, is that gout or is it something else? And I think that's really where the dual energy CT is really useful. But I think it's actually really unusual for there to be diagnostic uncertainty where a dual energy CT actually makes it clear. I can think of a handful of cases where that's been the case, actually. As much as we love the fancy imaging, I think most of the time it's the old school.
The history and physical exam.
Yeah, history exam, physical exam.
Yeah, I've certainly used dual energy CT in settings where you have somebody with clear gout, you bring down their uric acid to 4, and they continue having pain, right? And it's like, is this still gout, right? Did they twist their ankle? Do they have just like a tendonitis that's just not going away? Is there something else going on? And in that case, it's been helpful.
Yeah, and I agree. I mean, I think I've certainly seen someone recently where I had that question where they're actually, they'd clearly had gout previously. They had had their serum urate well controlled for about 2 or 3 years. And I sort of thought, still getting the odd inflammatory kind of niggle. And I was kind of like, is this still gout? Am I missing something? And the dual energy CT was very useful because actually it did show some small persistent deposits. And I was able to say to the person, actually, yes, I think this is gout. We'll just keep doing what we're doing and it should settle down over time. So I agree. I think that's certainly a place where it can be useful. I think ultrasound can also be useful in the same way if you're able to do ultrasound in the clinic. Yeah.
And do you think that these imaging studies, that they're so good to picking up uric acid deposition in the joints? So is every gout tophaceous gout, right? Because I imagine if somebody that has podagra, if you do dual energy CT, you'll find collections of uric acid crystals throughout their foot. So is every gout tophaceous gout?
Well, I think the tophus is a very specific lesion. So, a tophus is basically a collection of MSU crystals surrounded by chronic granulomatous inflammation. I think that we don't know for sure when we're seeing crystals on ultrasound or on dual energy what the whole composition of that lesion is because, for dual energy, for example, we're really just seeing the crystals. I think certainly when we look at the older studies, when we look at some of the imaging, I think it's very clear that what we appreciate on our physical examination underestimates the degree of MSU crystal deposition. So I do a lot of scanning for both research and also in my clinical practice, and most people will have deposits, double contour sign, in joints that have never been inflamed. There's clearly a lot more MSU crystal deposition than we clinically appreciate. We also see quite a lot of MSU crystal deposition in people who've never experienced a gout flare before, so an asymptomatic hyperuricemia. And I think this does raise a really interesting question about, is gout the crystal deposition, or when does gout start? I think we have done some quite useful work as a gout community around this. And so GCAN, which is the Gout Crystal Arthritis Research Group, has done some really interesting work as a community, kind of defining what these disease states. And I think that at this stage, we would consider gout present when there's MSU crystal deposition and there's clinical features of gout, by which we mean gout flares, chronic gouty arthritis, or tophi. And I think that's really important because I think there is a risk that we have creep into treating MSU crystal deposition alone without clinical manifestations, without really understanding the risks and benefits of that. And certainly the data that we have to date for asymptomatic hyperuricemia indicates that there's probably not a lot of clinical benefit to treating elevated serum urate concentrations alone. Most people with hyperuricemia won't develop gout, so we're going to be treating a whole lot of people. If we do decide to treat asymptomatic hyperuricemia, potentially we're treating a whole lot of people without obvious clinical benefit, at least with respect to their joints, and probably also with respect to things like cardiovascular outcomes and renal outcomes based on the available data. I certainly don't treat asymptomatic hyperuricemia in the absence of symptomatic gout. I think I would really want to see a lot more compelling data that there's benefit before doing that.
Got it. That makes a lot of sense. You mentioned patients with gout often have comorbidities, cardiovascular disease, renal disease. So is there any data that, in somebody that actually has gout and is hyperuricemic, and that, lowering the uric acid helps to improve their cardiovascular disease, helps to improve their blood pressure, helps to prevent progression of renal disease? Or is it totally separate and has nothing to do with their other comorbidities?
I think this is still a very controversial area in the field of crystal arthritis and in gout. I think there's some very interesting data showing that the inflammation associated with gout is probably quite detrimental, particularly with respect to cardiovascular disease. So there's been this very interesting study just published in JAMA just in the last year showing that cardiovascular events are much more common soon after gout flares. And we already know that people with gout have very high rates of cardiovascular disease and increased cardiovascular mortality. It's not really clear that reducing the serum urate, either in people with asymptomatic hyperuricemia or indeed those with gout, by itself has benefits with respect to cardiovascular disease, or indeed, reduces CKD progression in people with chronic kidney disease plus gout. I think there are clearly going to be other effects. So, if you're not experiencing gout flares, you're probably not having so many NSAIDs. So, there's a whole lot of other things that are probably feeding into this as well. I think one of the really very interesting things has been these studies demonstrating the benefits of colchicine in the general population for cardiovascular risk reduction. And I think the really unanswered question in the field of gout is actually effectively treating inflammation with medications such as colchicine going to have additional benefits for reducing cardiovascular events for people with gout. And we don't know that at the moment. We know that it does in the general population, but we don't know whether that's also the case in gout. And it may not be, because actually people with gout may have a lot more systemic inflammation, or there may be other mechanisms for that as well in people with gout. But I think that's a really important unanswered question at the moment.
The other thing in terms of treatment that people sort of emphasize or perhaps overemphasize is the role of diet. To what extent can you actually lower your uric acid levels by avoiding purines, which is the typical story that people hear all the time.
Yeah, most people cannot reduce their serum urate to target with diet alone. Very, very few people can do that. I think that spending a whole lot of time on diet within the clinic is not a useful use of our time as clinicians. Most people with gout have heard these messages before, have made multiple changes to their diet because everyone around them is telling them to do this. And actually, often you need to kind of unpack this and say, actually, it's very unlikely that with diet alone, you're going to actually get your serum urate to target or get your gout under good control. My approach to diet is quite similar to the approach that I take for all people, actually, in my clinic. So if someone is drinking hazardous amounts of alcohol, I'll suggest that they reduce that alcohol. And I think that's also important for our patients on methotrexate. It's important for all of us, and our general health. Absolutely.
Yeah,
I think if people are drinking a lot of sugary drinks, again, not really that great for any of us. And again, that sort of general health advice, I don't think that eliminating purines out of your diet is actually sustainable. So I advocate a balanced, healthy diet, avoiding hazardous alcohol, a whole lot of sugary drinks, because let's face it, that's not going to be good for anyone. And then I just kind of leave it there. No one gets a sheet as they leave my office saying, don't eat this, don't eat that. Very sort of broad concepts, which are mostly focused on health. And it's a very small part of the conversation.
I love that. My concern all the time, when I started treating patients with gout is that if you tell them to avoid purines and protein, what are they going to be replacing those calories with? Is it rice and bread and all these things that aren't healthy, as opposed to like salmon and chicken, which is probably better. So I love that approach about reducing things that are bad for everybody, excess alcohol consumption and sugar drinks and things with high fructose corn syrup and things like that, and then medications as part of the treatment. Another treatment question. Tons of patients get admitted to the hospital who are taking allopurinol. When the admitting team puts them in, they get a warning saying that, patient has kidney injury, you should renally dose allopurinol.
Sorry.
And their allopurinol 400,
Yeah.
allopurinol 400 gets reduced to 100 or 50. Lo and behold, they develop a flare in the hospital. Should we be renally dosing allopurinol?
No, we should not be renally dosing allopurinol. Absolutely. Lisa Stamp, who's one of my colleagues in New Zealand, has done a huge amount of work on this. And, I've learned a lot from her and the work we've done together. So the answer is no, we shouldn't be renally dosing allopurinol. The dose of allopurinol that is the right dose for each person is the dose that gets their serum urate to target. When we start allopurinol, we should be starting low, and we do need to start a bit lower in people with chronic kidney disease. And there's a couple of reasons for that. First of all, we do know that the starting dose, particularly in people with CKD, can be associated with hypersensitivity, allopurinol hypersensitivity. So we want to start low. We also want to start low because, as we've already talked about, if we start low, people are less likely to have a gout flare. And also, people who have CKD probably don't need as much allopurinol to get their serum urate to target. Once they're on a stable dose of allopurinol, they should stay on that dose. There is going to be no risk to this person who's been admitted to hospital. If they're tolerating allopurinol, it's not going to do any harm, and it may prevent them from having a gout flare. And, the real risk is that person goes home on their 100 milligrams of allopurinol and never gets the proper dose again. Or there's this sudden narrative that actually this is now the dose because the hospital doctor has said this is the appropriate dose. And we don't need to, just don't change anything. Just keep doing what you're doing. Yeah, as in, the allopurinol dose, just keep it going. Don't fiddle with it at all in that acute setting.
Great. And the last treatment question that I have is about your thoughts about febuxostat. So initially it was great. It was like sort of 2 doses instead of allopurinol 50, 100, 150, 200. You're like, febuxostat 40, 80, you're done.
Yeah.
And then, the article came about the increased cardiovascular risk and death, febuxostat compared to allopurinol. And then some recent evidence, maybe it's not so concerning. What's your take, and when do you use febuxostat?
Yeah, what a journey that's been. So I think my situation is a little different where I practice in Aotearoa, New Zealand, because we have quite a lot of government restrictions on when we can use certain medicines, which is very much based on health economics. So essentially, the situation is that I have to use allopurinol before I can use febuxostat, and that's really a sort of health economics argument from our government. Just sort of going through the story of febuxostat, so obviously very effective urate-lowering medication. 80 milligrams is clearly more effective at urate lowering than allopurinol 300 milligrams. And that was really the phase 3 data. The CARES trial, published about 4 years ago now, had a major impact, demonstrated increased all-cause and increased cardiovascular mortality in that trial with febuxostat compared to allopurinol. A number of sort of issues with that trial, but ultimately a trial that was designed to answer that specific question. And there was clearly a safety signal there. There have now been 2 additional trials, which I think have provided a lot more reassurance around this. The FAST trial, which was essentially the EMA equivalent to CARES, published in the Lancet, which actually showed no safety signal with febuxostat, and if anything, a slightly lower risk of cardiovascular events and mortality compared with allopurinol. And then also importantly, the VA Stop Gout study, which was just published a year or so ago now. Again, a US-based study comparing allopurinol dose titration with febuxostat. And I think this is a really important trial for a couple of reasons. The first thing is, again, it didn't show any difference in cardiovascular outcome. And so I think, we now have 2 large trials which have been reassuring with respect to febuxostat. Importantly also, it actually showed that allopurinol, when appropriately dose titrated, for gout outcomes, is as effective as febuxostat, 80 milligrams a day. But, ultimately we just need to be dose titrating allopurinol and prescribing it well. And most people will require 400 milligrams of allopurinol to get to target. And we need to really kind of be monitoring the serum urate and dose titrating appropriately to get those benefits. So coming back to your question, my approach is really, I think allopurinol is still a very good medicine. I think we do have the ability to gradually dose titrate, and we probably see slightly fewer flares in that setting. But febuxostat is also an extremely effective urate-lowering medication. I feel much more comfortable now than I did maybe 3 or 4 years ago using it in people with cardiovascular disease because of this additional data that's come out.
Great. When talking to you have so much excitement about gout. How did that come to be? When did you start getting an interest in gout?
Yeah. So I became interested in it as a trainee. And I think I was a trainee in Aotearoa, in Tamaki Makaurau, Auckland. In Aotearoa, we have extremely high rates of very severe gout. So in our country overall, we have around, about 1 in 20 adults has gout.
Wow.
And in certain populations within Aotearoa, particularly Indigenous New Zealanders, Māori, and also Pacific peoples living in Aotearoa, very high rates of gout. So if we're looking at older Māori men, about 1 in 3, older Pacific men living in Aotearoa, about 1 in 2, so almost 50%. So it's a really common thing that we see a lot of in New Zealand. We also see extremely severe disease in young people. And so it's a really important health issue for us. And I think there's so much that we can do in gout. It's, we kind of think that we know everything about gout. For a very long time, that MSU crystals are the cause of gout. We know that there are effective therapies. We've had these, as we've talked about, for, over 50 years. We do have some new therapies as well coming through, but actually there's still so much to learn. And, I think we've seen that in the last 10 to 15 years with all these new discoveries of urate transporters and understanding the biological basis of the disease. And there's still so much to learn, and there's so many benefits that we can see for patients. And I think on a day-to-day basis, I see the impact that gout has on people's quality of life. And, I think we've learned a lot about that from listening to patient stories and hearing about the impact that gout has on their ability to work, on their family life, on all domains of their life, and also what really good gout management feels like and how liberating that is for patients. And I think there are huge opportunities here for improving people's quality of life. So that's why I'm excited about it.
No, that's great. What is it about the indigenous people in New Zealand that makes them prone? Is it, again, do they eat a lot of purines, or do they have some genetic issues with urate excretion that may make them more susceptible?
I don't think it's clearly known. I think that there's certainly some differences in uric acid excretion through the kidneys, which have been well documented for many years, and some of that may be genetic, and we're certainly doing some work to try and understand that. I think there's also major issues around social determinants of health that will feed into the risk of gout, particularly which also impact on risk of chronic kidney disease, risk of diabetes, and also really important issues around access to equitable care. And so, what we see in Aotearoa is we see those ethnicity groups who have the most severe disease, largest impact of disease, less likely to receive urate-lowering therapy. So there's huge issues around health equity that really we also need to be addressing. And so, I think it's actually quite complex. So I think there's clearly biology aspects. There's also a whole lot of other issues around access to good care, impact of comorbidities, experience of racism within the healthcare system, a whole lot of other things that occur as well that are really important to think about as we're thinking about this whole experience of having gout in Aotearoa.
And I wonder if you know anything about inequities of gout management in other places like the United States, because it seems like, just like it is in New Zealand, management of gout in underrepresented groups or in people of different economic statuses probably plays a large role in outcomes.
Yeah, I think that's certainly the case. So again, I think there's certainly some emerging data now from the US where there are clearly health inequities based on race or ethnicity, and also I think there are some gender inequities as well. So coming back to your original question and comments about the older man, I think that we see women with gout also being much less likely to receive urate-lowering therapy despite having similar experience of gout flares and severity of disease. And I think the challenges for women with gout there are some real challenges. There are these kind of narratives around gout being a men's disease. There may not be resources that are available for women with gout. So there's certainly increasing awareness of this now, and I think we need to be looking at the messaging that we have for different people with gout so that it's not focused on one specific demographic.
Great. In looking towards the future, you sort of were mentioning about other treatments. What's coming down the pipeline for the management of gout? What's still needed?
Yeah. So look, I think there's some really exciting new urate-lowering therapies that are in development. I think one of the really exciting things in the US at least has been this sort of work with pegloticase and particularly understanding how to use pegloticase better. And I think also some really exciting looking new anti-inflammatories that might actually prevent or more tightly target the gout flare and gout inflammation without the side effects that we see commonly with our standard anti-inflammatory therapies. So I think that that's one aspect, the medical management or the medicines. But, I think as we've talked quite a lot about, I think really the key focus needs to be on using our existing medicines much better. Actually, I think having another medicine is not going to solve necessarily the burden of gout in our community. And I think we need to think much more broadly about actually involving many different types of healthcare professionals, changing messaging about gout, actually looking at how we deliver chronic care management within our community. And I think those kind of strategies are going to be really important. And I think also actually looking at our environment and what's within our environment that's actually contributing to increasing rates of gout as well, be it increasing BMI, increasing inactivity, really unhealthy food environments, and also prevention of chronic kidney disease and other metabolic diseases. So I think we need to look much more holistically at a gout prevention and also making care easier and better for patients.
I love it. I think I couldn't end this in any better way than that. Nicola, I really appreciate your time. This has been really enlightening for me. And I hope that this also helps, all the patients with gout out there in the world. Thank you so much for all your work that you do with gout. And thank you so much for your time.
Great. Thanks so much.
Well, I hope you're excited as I am to treat your next patient with gout. However, we'll really need your help in making structural changes if we are to make a dent in this ancient disease. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this episode at acronair.org, Apple Podcast, Google Podcast, Spotify, and on your favorite podcast app. Until next time, keep bringing that uric acid level down to target. And of course, stay healthy.